So I'm Bethany Hamilton, co-director of the National Center for Medical Legal Partnership. And we are so happy to be able to, hang on one second, I see chat popping up. We're so happy to be able to be partnering with Futures Without Violence and Health Partners on IPV and Exploitation. You are joining us here today on May 19th for session 3 of our joint peer learning collaborative on collaborating to address the health and legal needs of patients experiencing intimate partner violence and exploitation. If it hasn't shown up for you on the screen yet, use Zoom to go ahead and make the chat function show up. As you'll see on the chat already, or if it's popping up for you via alerts, we are taking a moment to let everyone know who we are, where we're from, the type of organization, our names and pronouns that we'd like to be able to use to be addressed. So if you wouldn't mind, and I'll do the same as well in a second, let us know who you are, what organization you're with, your location, and then pronouns. Share that in the chat. So let's go to the next slide. Just getting some housekeeping out of the way and making sure that our friends who are not able to join live today are also able to take advantage of this entire series of recordings. So this is funded by HRSA, the Health Resources and Services Administration. Again, I'm Bethany. I'm representing the National Center for Medical Legal Partnership, and I also have my colleagues Danielle Rahajason and Catherine Stinton joining here today. So feel free, if you have MLP-specific questions or need resources, plug that question into the chat, and they are really quick with regard to finding the links and sharing them. I'm also joined by many esteemed, awesome members of the Health Partners on IPV and Exploitation, part of Futures Without Violence, and TAP, and together we are funded to provide this training and technical assistance experience for you. Let's go to the next slide. So Elena, I want to see if I can do what you did for me, which is pass the mic to you to provide the proper succinct introduction of Health Partners on IPV and Exploitation.
Hi, everyone. My name is Elena Jocelyn. Can you hear me all right? Okay, great. And I work at Futures Without Violence, and we lead a national training and technical assistance project called Health Partners on IPV and Exploitation, funded by HRSA and BIPIC, and we work with community health centers and domestic violence programs and other community-based organizations to support those at risk or experiencing intimate partner violence, human trafficking, or exploitation, and to think about prevention too. And our website is on the slide, and you can look at our tools. We've got a lot of sample tools on there that might help you with as you develop these partnerships, and we'll share a little bit more in some of those tools later on in the webinar today.
And thanks, Elena. And as mentioned before, I'm Bethany with the National Center for Medical Legal Partnership. We are based at the George Washington University in DC. And our whole mission is really all about creating those integrated healthcare systems that, as a normative, include civil legal services or legal services professionals to be able to address those social needs that have legal underpinnings, and allow our healthcare providers and healthcare systems to be able to improve health equity, quality of care, and address and remove those barriers to population health. Through this learning collaborative and other training and technical assistance resources, we're really geared under the HRSA work to be able to help health centers in particular through MLPs address health-related legal needs of the patient population that they serve, increase the number of patients that are screened for those social and legal needs, and then actually help you, such as through learning collaboratives like this, implement those MLPs to address the social determinants of health. We're looking forward to hearing from you all joining us here today about what you're doing and what you need to be able to get those things done. Let's go to the next slide. All right, so before we kick into the substantive matter that we're discussing, we do want to make sure that we note that this is a virtual webinar training experience. You are welcome to, turn off your cameras, go on mute, but also unmute, come on camera. We're talking about some pretty heavy topics, some of which, many of us have either experienced or supported others in terms of surviving those experiences. So because domestic and sexual violence and human trafficking are so very prevalent, let's just assume that there are survivors here among us. And so just beware of your reactions, take care of yourself first and foremost, especially this week. Especially this week in light of the violence that we've seen of late. So it's okay to also take the step away from the Zoom. We are recording this today, and you're welcome to tune into the recording. We'll all continue to respect our patients' and clients' confidentiality. So if you're sharing through the questions or thoughts, any stories or case studies, let's just maintain confidentiality. All right, moving along, some of the housekeeping, we need to get those things out of the way and taken care of. We have learning objectives, 3 learning objectives, 1, 1, and 1. They're all high priorities. So number 1, just want to make sure we continue to ground ourselves through this learning collaborative in the learning objectives. Number 1, our goal here is to ultimately facilitate a conversation with you to help you identify strategies to build these partnerships, whether they are formalized or informal, MLPs or not MLPs. There are many different forms of community-based partnerships that we believe can be utilized to better address the needs of the patient populations that we're serving. Secondly, we're hoping that through this learning collaborative, you'll be able to better describe strategies for sustaining and growing collaborative health justice responses for both preventing and addressing IPV. And then number 3, we're hoping that we can help you to identify a few tools, at least 3 tools that can help you as health centers, civil legal services, social services, DV advocates formalize those partnerships and develop protocols for responding to DV, IPV, and human trafficking, and build prevention strategies. So those are our learning objectives. Keep those in mind as our subject matter expert, Nikole Nelson, leads a discussion with you on how she's getting some of this work done in Alaska. Let's go to the next slide, please. Thanks, Camila. So as I alluded, you will be hearing about Alaska. Today's session focuses specifically on scaling and sustaining medical legal partnerships, that specific partnership approach to be able to address intimate partner violence and exploitation. You'll be hearing from Nikole Nelson, I believe. Let's go to the next slide. I think. Yep, we've got Nikole Nelson showing up on this slide. This is the entire panel. We do have Dr. Kimberly Chang here in case there are questions that are geared towards the clinician field, and then the entire teams from the National Center, as well as Health Partners, IPV, and Exploitation are here today. So let us know what questions you may have for us. But Nikole Nelson is joining us here from Alaska Legal Services. She's Executive Director. And if you happen to be at the recent NLADA, ABA Equal Justice Conference, you probably saw her at one of the gazillion sessions that she was leading for civil legal aid folks to learn more about the work that she not only does in the MLP space, but as a civil legal services leader, not just in Alaska, but around the country. So we are so happy to have you here today with us, Nikole. I think the next slide is probably just another highlight of you as faculty, but I do want to waste no more time and pass the mic on to you to begin your presentation. Thank you everyone for joining us. Get ready to unmute when it's time, or at any time you have questions for Nikole. Nikole, all yours.
Great. Can we go next slide, Camilla? All right, so as Bethany mentioned, I'm Nikole Nelson, and I'm the Executive Director of Alaska Legal Services, and it's really great to be with you all today. In talking about today, the topic of the session is scaling and sustainability. And so for me, when I think about scaling and sustaining our models, they are really rooted in what our community needs are. And so when I think about how to build and sustain a model, we really have to have an understanding of 3 things in my mind. And one is the landscape, an understanding of the landscape that your community is sort of a landscape mapping of your community, and understanding what your community's wants and needs are with respect to justice and improving wellness, and then also getting community buy-in. So those are the 3 things I think about in creating and sustaining these partnerships. And so I want to tell you 3 because I think they're very community-based and different for each community. I want to just tell you a little bit about mine and how we grew our network. So next slide. First off, I'll tell you that our medical legal partnership which is pretty unique. We have four aspects that relate to it. This partnership combines legal aid, healthcare, education, and technology. And so what we're really trying to do through this partnership is to figure out a different way to infuse our healthcare system with legal knowledge, such that these health harming legal needs can be addressed through our healthcare system, and using technology to assist in that, as well as combining the way that we are delivering our legal knowledge to the community through working with educators. And so we have really great partners that Alaska Legal Services is working with. Our partners in our project are the Alaska Native Tribal Health Consortium, which is the largest healthcare system for Indigenous people in the nation. And also Alaska Pacific University, which is a tribally controlled college that is affiliated with the Alaska Native Tribal Health Consortium, which helps build up a community-based healthcare workforce. And then, of course, Alaska Legal Services. We are a nonprofit legal aid organization that has been serving our state for about 50 years, over 50 years, actually. Okay, next slide. So some more things you should know about the community that we find ourselves in. So Alaska is huge. It's really big. It is, it is 1/5 the size of the lower 48. If you overlaid it across the lower 48, it would stretch coast to coast, and it is bigger than the next 5 states combined. So that is, if you could put California, Montana, and our little sister state, Texas, all inside of Alaska. And so we're a big state, but we're also very dense, or we have a low population density. So there are less than 750,000 of us, and we're spread across the state. Okay, next slide. One other thing that's really important to know is that we are proudly home to 229 Indigenous tribes. About 20% of our entire population is Indigenous, and that makes us proudly the most Indigenous state in the Union. I live in Anchorage, Alaska, which is the contemporary and traditional homelands of the Dena'ina people. And I have had the good fortune of living here and working here for 25 years. This is a slide of Anchorage, which is the community in which I live. It's a big city. It's nestled in the mountains and in the sea, right across the sea. This is in wintertime. In the summer, it looks a little bit more green. But this is also where half the population, a little bit more than half of that 750,000 of us live in this city. Next slide. The remaining part of the population lives in communities that are off the road system, and they might live in little villages like this one. This is Gweethlik. And so these communities range from maybe 30 people to up to a hub community that might have 6,000 people. But these are really small communities, and they aren't connected to the road system. Next slide. Which means if you see this line here, or this slide, the road system where the little white lines are on that are the only roads in Alaska. And all the other communities you need to fly into them and you can fly into them, or they're maybe accessible by snow machine, or in the summer by river. But other than that, there aren't many roads. And so that really impacts the world that we developed our medical legal partnership in. Okay, next slide. So again, that road system, which is built along, the road system was built to facilitate the extraction of oil and other resources from our community. And it also happens to align with where all the white people live for the most part. That means that a lot of our really remote and those other communities that don't have access to the road system also don't have access to other basic infrastructure resources. Our state has not invested in those areas as much as they have in the other places. And so there are at least 75 Alaska communities that have no law enforcement presence, and most villages lack regular access to police, courts, or other related services. That includes some of them also lack access to indoor plumbing and other just basic infrastructure services. Next slide. And one of the really challenging things that that is really difficult for our communities as a whole in our state. We rank highest in the nation, one of the highest states in the nation for rates of domestic violence and sexual assault. And this disproportionately impacts our Alaska Native sisters. And there are very few resources. As I mentioned before, you might not have law enforcement access to law enforcement or a local domestic violence shelter or other services that folks who live on the road system or in the cities might be able to access. And it's important to know too that oftentimes in these communities, public safety help might be a plane ride away. It may take 48 hours for somebody to come and be at your service. So, okay, next slide. In addition to having infrastructure problems, a very light infrastructure in our most remote communities, there is little access to civil legal help. So like most legal aid organizations in the world, across the state, Alaska Legal Services, I'm proud of the fact we serve our community. We do the best we can with the resources that we have, but unfortunately, because our resources are limited, we have to turn away one person for everyone that we are able to serve. And we also know, based on national studies, that 80% of the folks that need us don't even make it to our door. So again, there is a huge gap, a huge and wide gap between those who need our services and those who are able to get them. And so this is the landscape that we really found ourselves in 2017, around 2017, time's fuzzy now, when we decided to come together as a community, decide how we might fix some of these interrelated problems, which are, accessing legal assistance and helping people who are experiencing IPV. Okay, next slide. So one of the first things that we did when we came together as a community, we gathered their justice stakeholders and other stakeholders within the community. And we wanted to do a community mapping exercise. And so what we did, we wanted to find out where the justice services were. And you can see on the, so for you, I guess, well, on the one side where there are the blue and yellow dots on the screen, these show where all the private lawyers are located. And you'll notice, of course, it will probably come as no surprise that they're mostly on the really populated areas and along the road system. And then we have a little bit more distribution of legal services or justice related services where those green dots are. And those are mostly Alaska Legal Services offices and some court systems. But you can tell that if you remember from a few slides back, there are so many communities that have access to none of these services at all. So we knew that we did not have our footprint was not very broad. On the other hand, we wanted to look and see, we know that our remote communities have, there are some infrastructures there, and we wanted to see what services were available in most communities. And we learned through this community mapping exercise that the Alaska Native Tribal Health System had the widest footprint within our state. Each of those little communities down to one had a community health aide. And we also, and there was also, and oftentimes there were those intertwined with like the tribal council. So when we looked at this, we realized that our tribally operated healthcare system and the community health aides had this biggest infrastructure within our state. And so we really wanted to figure out a way, if there was a way for us to collaborate to better expand our services and to reach those folks that we were missing and to try to deliver services in a different way. Next slide. So we wondered, though, at this time, why would the healthcare providers want to work with us? We knew we wanted to borrow their infrastructure, but we didn't know at that time why they might be interested in working with us. And so we set about to find out. We had a conversation and convening with healthcare partners. And one of the things we learned, and I have to tell you that this was really awakening for us and really transformed the way we thought about doing our work. So a couple of things we learned. First off, we learned that healthcare only represents 20% of why a person's health is only related to healthcare. 20% is related to genetics, and 60% is related to the social, environmental, and behavioral health factors, or social determinants of health. And we looked at what those social determinants of health were. Next slide, please. And we realized that there was a great overlay between the social determinants of health and the civil legal needs that that people are facing, that legal aid is really good at addressing. And so we thought, this is fantastic. And we found that there was commonality between us and our healthcare partners, that we had a joint mission and something that we could work on together. We also understood through learning from our healthcare partners and justice partners talking together that that health outcomes were being disproportionately impacted, that the justice-related barriers were addressing, that justice-related barriers were really resulting in health inequities across our state, particularly in those who are the most marginalized in our folks, our Alaska Native brothers and sisters who are in very outlying communities. And so together we decided that we wanted to work together as a community to see if we could join forces to address these issues. Next step. And as part of this, we learned from the Alaska Native tribal healthcare system, which is really has a really broad vision of how they were going to deliver services. We learned from ANTHC, whose vision is that Alaska Native people would be the healthiest in the world. They had been working for many years, decades even, in trying to build up a community-based, culturally informed workforce. And that meant that the community health aides within each of their communities, they had been developing training programs where they would recruit people from the local community and provide them the skills that they needed to serve that local community, rather than importing medical or highly skilled professionals from outside those communities to come into the community to serve them. And they had training programs that they had been using with Alaska Pacific University to build up this workforce. And they had a network of over 550 community health aides and practitioners. They also had mid-level practitioners related to behavioral health aides and dental health therapists. And these were all folks that come from the communities, our remote communities, who are providing online distance learning asynchronous curriculum that would help them understand and develop skills, healthcare skills. And we thought at first, this is really amazing. What we would really like to do is see if we can infuse the community health aides and practitioners with a little bit of legal knowledge so that they could help us screen and surface unmet civil legal needs. Next slide. And so we set about trying to do that and developing a medical legal partnership that would train healthcare providers all the way down to the village level, that would help treat patients' legal needs and develop a legal treatment plan for them. And that would also sort of transform it says here the traditional healthcare delivery system, but I don't think that the Alaska Native tribal healthcare system is traditional in any sense of the word. It's very forward and thinking, but would transform healthcare by using legal assistance to address health-related needs, and also as a means of addressing health inequities. And it would also prevent legal problems from escalating as well. Next slide. So during this process, we also, we thought, as we were training, or, it's building a medical legal partnership that would infuse legal knowledge within our healthcare workers, we also wanted to follow the tribally operated healthcare systems model of developing mid-level practitioners. And so we are hoping to, we started developing our own mid-level community justice workers. And we did this through asynchronous on-demand distance learning through APU. Next slide. And so over the course of the last 5 years, we've developed distance learning modules that aspiring community justice workers can take, or healthcare workers, on several areas that were unique to our community, but not unique, but they were identified by our communities as unmet needs that impacted both health and justice. So for instance, one of the problems our states faced was addressing food insecurity. And of course, that has obvious impacts on health. And we learned that many of our remote communities were not being able to access the SNAP benefits to which they were entitled because of the infrastructure problems. And so we developed SNAP modules, training modules that would that were aimed at teaching folks and at the community health aides what the rules are related to SNAP benefits and what to do if people weren't getting them. And then also anyone who takes this course would be able to help a community member appeal a denial or access public benefits. We also did one on ICWA, which is Indian Child Welfare Act. These are folks that represent the tribe's position in child in need of aid proceedings. We help folks with wills. This was another issue that and also decision-making decision-making documents, debt collection, and then also domestic violence, obtaining domestic violence protective orders. And right now we've got, we have recruited about 200 and just over 200 community justice workers. 100 have completed the modules, and we have 101 that are progressing through them. Okay, next slide. So again, what we're doing through our community, through our medical legal partnership, is leveraging pre-existing infrastructure and combining it with new innovations to build a community justice workforce to reach our most remote communities. And we're pairing this with distance learning, also with technology. And so one of the things that will be coming online this summer is a legal navigator portal, which is being developed by the Legal Services Corporation in conjunction with Alaska and Hawaii's court systems and legal aid. And this is an idea where we would combine sort of all the self-help legal knowledge, legal information that we have. And so somebody could say, oh, I'm experiencing domestic violence. And when they do that, they're through natural language processing, they can answer some questions and a plan will come up for them, a legal plan to help address that will come up for them. And what we imagine we'll do is we will then train our community health aides about the legal navigator so that then they can walk people through it. They won't need to understand all the ins and outs of all the legal procedures, but they will have access, they will know to reach out to this tool, which will help screen, surface, and develop a treatment plan, a legal treatment plan for our for those who are experiencing those symptoms. So that's coming out this summer. And also we are developing a web-based application that helps those working in medical practice help people get on and Social Security disability. So oftentimes people who have disabilities or have trouble accessing that service, they get denied because their paperwork isn't in the right format or they haven't provided the right documentation. And so this is sort of a checklist that helps those social workers working within healthcare systems to go through that process, and it's been co-designed with our healthcare social workers. And so that will be coming out this summer too. Next slide. And so, you know, during this time, as we were growing our medical legal partnership, I also should mention that we have attorneys also embedded in different medical facilities, in addition to training healthcare, the community health aides and other social workers about legal aid. And so we have attorneys embedded in the healthcare system, and they are also connected to the overarching legal services footprint that Alaska Legal Services has. And over the course of this, you know, 2-year period, we haven't updated this since before the pandemic, but we really should. We were able to show that we had increased the work that we had increased our services. So we were able to serve an additional almost 1,500 Alaskans. Now, maybe those are small numbers for you folks, but those are big numbers for folks who have such a lower population. We had an estimated economic benefit of drawing down $2.6 million into our state in making sure sure that folks qualify for Social Security disability, SSDI, which is another form of Social Security, and Medicaid. And then we also estimated over $500,000 in savings related to placement in emergency shelters and injury avoidance in domestic violence cases. So we were able to show that there was a 6-to-1 return on all funds invested in our program. Okay, next slide. And as relates to scaling and sustainability, one of the things that our medical legal partner, which is unique to our medical legal partnership, we wanted to be able to scale this up with our partners, throughout those who are serving Indigenous communities, legal aid programs who are serving Indigenous programs in the lower 48. And so one of the things that's unique to tribal communities is we all share sort of a lack of infrastructure because funds have not been invested in these programs as well as other places in other communities. And so in 2019, we expanded through an AmeriCorps program to help seed other medical legal partnerships in tribal communities in the lower 48. And so as of 2019, we were serving 233 tribes in 13 different locations through a shared infrastructure of Alaska Legal Services and our other legal aid providers, which that operate in Indian country, which we refer to as NAILS. Okay, next slide. So now I wanted to, so that's just sort of the background of the conversation, or just sort of to let you know how we got to where we are and how we built our medical legal partnership and sort of what we see the future of it is. And so I was hoping that we could now have a little bit of a conversation for you to help you think about if you wanted, if a medical legal partnership makes sense within the communities that you're working and how you might figure that out. And also how you might figure out what information you would need to grow and sustain your networks. So next slide. My first question is, and I hope that, I don't know if folks feel comfortable coming on camera, they'll do so now or come off mute. And we could just have a conversation. First, you're welcome to ask me any questions you might have, but also I'd like to hear from you about what you think it would be important for you all to know in your community to understand whether a medical legal partnership might make sense and what it might look like.
Please feel free, everyone, just unmute, even if you just want to start off with just asking Nikole questions about all that she featured. I literally sent off text messages to a couple of people about what she presented. So I have more questions as well. Please feel free to just hit unmute, raise your hand if you don't want to talk over anyone else.
Could I ask a question?
Absolutely, absolutely, go right ahead.
Well, this would apply to her and maybe in general, but would one way to do this is to simply look at a community at the intersection of social services and legal needs? Like, I mean, for example, housing, being, a legal obligation that, children example should be in a home, but it's also a structural determinant of health. Does that make sense?
Yeah, absolutely. I think that's, that is absolutely the right way to go. I mean, a lot of the work in our MLP, you looked at sort of the 5 areas where we were developing modules. It was really related to the needs that happened within our community that we were all trying to address, right? And so domestic violence is there, it's food insecurity. Housing is really such a need. I don't know anywhere in the universe where housing is not, a unmet need right now. And it's so there's such clear indications how it impacts health. Yeah, absolutely. I see Cynthia's got her hand up.
Hi, thank you for this valuable information. I'm wondering, I love the use of technology, but I'm wondering, did you have to hire someone who was tech savvy? We have a current program now, and I can't imagine any of us being able to pull this off. So I'm wondering how you were able to be so innovative and to think through the technology aspect of it.
Yeah, so again, it was really born out of the partnerships that we developed. I mean, one of the great things about the MLP that we developed, I mean, we were really going in thinking, we just want to borrow some infrastructure from our healthcare partners. And instead, it really just reshaped everything, all the ways in which we were doing business, right? And so it turned out our healthcare partners were a lot further ahead of us technology wise, and also a lot more forward thinking about how you would deliver services in different ways. And so one thing, the asynchronous on-demand learning platform that came from the tribally operated healthcare system. They have distance learning specialists who were developing those modules, and APU. So the Alaska Pacific University. So I guess I would say, like, we aren't relying on ourselves. We bring the legal expertise to it and a listening ear. And then we look for partners who will help us marry those things together, right? And so I guess my advice would be, like, no, we are not, I am not a technology expert, but what I am good at is finding partners, right? Who can bring those skills and trying to figure out a way where we have mutual interests and we might be able to move the ball forward collectively. And sometimes technology can look like, I mean, you know, some of our remote villages don't have a lot of technology infrastructure. So, you know, a phone works just as well. And a fax machine is Zoom sometimes, you know, you can get the information. Does that help?
Yes, thank you so much.
Yeah.
Nikole, I just wanted to make sure before you move on from Cynthia's question, you identified at least 3 different partners. I want to make sure we capture that. You identified healthcare for sure, because of the infrastructure. Let's think things like meaningful use, right? There are incentives built in to drive healthcare forward on technology and data integration. But you mentioned, I think, at least 2 other partners. So just want to make sure we capture that. I think you also mentioned, and please go ahead.
No, Alaska Pacific University, which is, you know, it's a university. It's a tribally controlled college that focuses on, you know, developing, providing education, but through a lot of practical hands-on learning.
Mm-hmm. Thank you. It's as you mentioned that, Nikole, I just wanted to put in a plug for everyone working with CHWs on CHW trainings. There is a NOFO out right now from HRSA, Bureau of Healthcare Workforce, and it is all about CHW training. So if you're in this space, you've created the trainings, like Nikole has mentioned with her MLP, for CHWs to get trained in MLP and health justice. You know, take a look at your partners working in that space to see if you can bring more resources to the work that you're already doing to help upskill or create new pathways for building up the CHW workforce, which are crucial members of the MLP workforce as well.
I will say, with respect to the technology piece too, when we had developing the application, the Social Security application, web-based app, and also the Legal Navigator, I mean, we applied for grants for those particular things to help us bring that technology to life. But again, I think the common thing is we met with our partners and listened to them and tried to figure out what were particular needs that we all agreed needed to be met, and thinking about what would be the best way to move that forward. And then we went out searching for our outside resources that we could use to inform and help our community based helpers. Yeah. Okay. Does anybody else have anything they've thought about that it might be important within their community to know or to think about when they're trying to figure out whether an MLP makes sense? Okay, then we will move to the next question. Okay, so another question I think along these lines is just trying to figure out, who are you going to get together to make this decision? Who is the community, or who is the community that you're trying to influence? So does anybody have thoughts about that? Who you might want if you're gathering your people to have these conversations, who's involved in those conversations? So I can tell you a little bit of how ours started. The first conversation really came from our Access to Justice Commission, which is mostly justice based. It's like our Supreme Court and lawyers and legal aid coming together. The second place where we gathered people was really our healthcare partners. And we combined, so we invited really healthcare partners across the state to come together and meet with our justice partners. And those were leaders, so like the CEO of healthcare systems, we had doctors, we had, the community health center in Anchorage, all of anyone really, we threw it open and we had, the other question is how to get people to come. There was a local foundation, which, it's a big local foundation here, and the head of the foundation, we asked her to hold the convening for us and to, send out the invitations, and she did. And then we all came together to have this conversation. So what do you all think? Who might you convene to start the conversation?
Nikole, this is Kim Chang here. I'm wondering if you folks also included, or subsequent to your formation, included the domestic violence advocacy programs.
Yeah, that's a great question. So what's interesting is at the beginning, we didn't. We started with our healthcare workforce, but because of the other work that Alaska Legal Services does, we also have attorneys embedded in shelters, in domestic violence shelters. And so we have had those type relationships for a while too. And I think if I stepped back, I probably would have, done that because I think it would have been really useful. So now we're sort of a little bit ahead and trying to, now we're not roping in, but like bringing in the domestic violence advocates and shelters a little bit later. But what they're providing for us is, as we're developing the domestic violence modules, the domestic violence advocates and shelter are being the subject matter experts for those and helping us understand helping us, we're legal experts, but we don't, we aren't the experts in that area. And so we're bringing them in to be, to help us fill out the education and the modules that we're turning out. And one of the things we're really excited about on a forward-going basis, we are hoping in the next year to develop an apprenticeship program for remote folks who would be community justice workers and in areas related to domestic violence. And so what we want to do is recruit a small pod, a cohort of 10 folks from remote Alaska, and over the course of a year, provide them with hands-on practical experience serving Alaska Legal Services clients in areas related to domestic violence. And so as part of this cohort, they would move forward together, but they would have two co-directors of that program. One is going to be a shelter, like a social worker that has a particular emphasis in domestic violence, and then a legal director. And so the two of them will work collectively to grow up sort of through an apprenticeship program, community justice workers that are able to address the needs of those who've experienced IPV. And we hope that our Supreme Court will give us a waiver so that they will be able to practice without having gone to law school.
That's awesome. And a follow-up question is, now that you've been in existence for a while, do you get clients or former clients or people who are using your services to help inform your strategy? Just like community health centers our board has to be, a majority of the board of directors have to be consumers or patients of the health center, right? And so just wondering if you get that really granular ground level input.
We do. So Legal aid organizations, or at least the LSC funded ones, also have a requirement that our board, at least half of our board, be our client eligible. And so that's one way in which we do that. Another way in which we gather that information each year, we do outreach to our communities and surveying to set priorities, because again, as I mentioned before, we have limited resources. So we have to sort of decide what services we're going to provide. And we believe in setting those at the local level. So each year we talk to folks in the community. That includes clients, former clients, and then also our community partners, like the organizations, to survey sort of what those needs are and to help us make decisions about what we should focus on.
So that's interesting because as you develop these issue-based focuses, right? Give me an example of some of the issues that you might focus on. Like, is it homelessness or social security or something?
Yeah, right. Like homelessness, like social security, preserving housing, preventing foreclosure, or, a big need in our community, in our remote communities, is accessing behavioral health services, which aren't readily available. So, that can be, those are examples.
So my then thread of this thought is that, domestic violence and exploitation probably carries through all of those different issue topics. So how would that be elevated? Because you wouldn't want it to necessarily be its own, well, maybe you would, you might want it to be its own issue, but then also you want it carried through all of those issues. How would you do that? Or are you doing that now?
Yeah, so right, because like our clients, they don't experience IPV and just in a vacuum. That's just not the sole issue, right? It impacts housing and whether you can get benefits and whether you can get a job and all of those things, right? So while getting a domestic violence protective order is one legal issue, if somebody is experiencing interpersonal violence within their home, there are probably a whole bunch of legal issues that they might be facing. And so, so we take the position that we aren't really looking. So some legal aid organizations prioritize their services based on legal strategy. We prioritize our services based on outcomes that we're hoping to achieve for our clients. So we want to, if somebody's coming to us, we want to make sure that they are safe and try to stabilize their housing, their life, whatever those things are. And that can take there are many different ways to do that legally. You might need to get them additional income supports. You might need to stop them from being evicted. You might need to get, assured that they don't lose their job if they're working at that time. So that's the way in which we would do it, is by focusing on the needs of the person and not the legal strategy that you would use.
Mm-hmm. And then would you just make sure that all of those issue-based legal services and the people are well-versed in how they're preventing intimate partner violence and the risks for exploitation by taking care of these issues? I just want to make sure that, that it's integrated throughout.
It's connected. Yeah, that's a good point. I mean, I need to step back and think if we do that in that way. I'm thinking about that now, and I think that might be an area where we could improve. I mean, I think we think about it and that's the way, but we should probably, that's a really good point. So.
Oh, I'm just asking because in healthcare, I do the same thing with our providers and the different medical issues. And when they get chronic disease flares, what is the cause of that and things like that. So just it's conversation, food for thought.
No, but it's so helpful. That's why I love working with our healthcare partners, because honestly, I find that they are so far ahead of the curve on us and it's just a really great partnership. I feel like we learn so much about just learning things that we could do to improve the way that we're trying to deliver services. So yeah, I love that. Thank you.
I wonder, Nikole, if we could go to the slide where you have your impact data on it.
Sure.
And maybe I'm jumping ahead in your question, but I wonder if we could take a minute to sit on that for a second. And my question is, you know, one of the things that I know a lot of programs and folks on this call are thinking about is how to evaluate the impact of a medical legal partnership, or even just an informal partnership with healthcare providers. And you all shared data about economic impact, about number of people served. And I'm curious if you started with the outcomes. It sounds like, you know, you were just sharing, you started with the outcomes that you want to see, and then figured out the data that you would need to achieve those outcomes, or if this is data that you all were collecting by nature of, you know, of what you needed to do as legal services providers or what a funder was requesting, and then figured out how to take that data and what outcomes that data showed. Does that make sense?
It
What's
does.
my question?
Yeah. So, well, two things I will say. So when we first started, we knew that we would want to collect some data about outcomes so that we could, you know, we heard from our healthcare partners and others that for it to be, that they were willing to invest to begin with, again, but they wanted us to make good on our promises, which was part of it. Like, these are the things we do. We think we preserve housing. We think we get people benefits. We think that we stop domestic violence. And they said, okay, that's all well and good. We're willing, you know, you've been around, you've been doing this work for a long time. We think we're willing to gamble on that, but we want you to start tracking something to show us. So we're willing, you know, we'll take you at face value at this point, but you're going to need to prove it out a little bit. And so we knew the things already going in that we were already tracking. And those really related to, you know, domestic violence, drawing down public benefits, and also preserving housing. And so we think we do a lot of other things too, but we weren't quite sure. These were the ones that were easy enough for us to track. And then there also were economic indicators within our state that we could apply a number to related to these things so we could come up with economic impact. So that's how we decided to track just these ones. That said, I mean, there are what we would hope to do and what our healthcare partners, you know, that we're still trying to figure out a way to do on a forward going basis is figuring out, you know, really if we're, you know, if we're improving health, right? And so trying to figure out how we might track that, that's something that would be of great interest to our healthcare providers and that we could try to figure out a way to do. This information has been really good though, to sort of keep our healthcare partners invested in providing the services. So we are able to show that, and it's good for now. We continue to have conversations about how we might, what other outcomes we might show. And we both have ideas about that too. So yeah, but I wonder, you know, for those of you, you know, we could talk about it, but for those of you who are joining us, do you have thoughts about what information would be important to the healthcare centers or developing a medical legal partnership, what they might want to know and what information you're already tracking?
If someone's willing to unmute. I feel like someone asked during the last session about, and I could be mixing this up with other trainings, but I thought there was a question from our participants about developing metrics.
Mm-hmm.
For determining which data to collect that goes into those impact statements that lead to showing value, like you were able to show, Nikole.
Mm-hmm.
Nikole, if no one has questions, can I ask you if anyone wants to reach out to find out how you and your partners were able to develop the performance measures and collect the data from the different systems, because we know civil legal services has a different data set in case management from healthcare, unless you fully integrated it in some way or you're working with a third party provider. If they want to, if folks want to reach out, might they be able to reach out to you to be able to figure out what that metric looks like? I feel like that might be a tool that's particularly useful for folks who are either just starting an MLP or somewhere along the path of their MLP implementation, and they might be on some sort of improvement strategy that's underway.
Yeah, absolutely. I'm happy to share.
Okay, thank you. How are we doing on time to be able to get to one of those other questions that Nikole has? I think we're okay. Okay, Nikole.
Yeah, so I think that sort of the last question I really wanted to get to, because I think we've talked about gathering the information, but have any of you really had any experience doing community asset mapping? Yes. Oh, so Kimberly, do you want to talk about that?
No, I think you should just go forward with your.
Okay. Yeah, so I just, for us, I think our community mapping exercise was really helpful for us. And really it just related to like sort of figuring out and, you know, what infrastructure already exists. So you can figure out ways to tie and leverage it to, you know, to transform services that you had. So I really, you know, I would encourage folks to do that. It was really transformative for us to have a better understanding of the landscape in which we are working. Okay. And let's see.
Nikole, I did have a question I received via direct message, and I just want to pull it out so that everyone can hear it and benefit from it, even if, right, we can't get to the full answer today. But I imagine there are a lot of folks in this situation. For newly developing MLPs, number one, does NCMLP or an MLP practitioner like yourself, Nikole, have some sense of or ideas related to successful innovations that other MLPs or that you've carried out to be able to address common health determinants such as housing, access to SNAP benefits, et cetera. Do you have a list of like six, or do you have examples, Nikole? And for the individual who asked this, yeah, we do have some examples that we can share from NCMLP, but I think they're outdated compared to what Nikole, who's currently running a medical legal partnership as a practitioner, can share with you on successful innovations. And timing may also matter, right, for what works and what doesn't. But Nikole, any response to that?
Yeah, well, what I would say, I mean, one of the things that was, you know, like honestly, our MLP started really kicking off at the time that the pandemic hit. And we really thought that, like, I thought it was going to crater, right? Because our healthcare partners had bigger fish to fry than, and needed, you know, things, it needed to focus on, you know, the pandemic. But it turned out that it really started to grow and flourish during that time. And one of the, like the big needs that happened within our community, for instance, is we realized that the aid wasn't being distributed into our most remote areas. And so this network that we had of lay advocates and community justice workers in integration with our community health aides could provide us lifetime feedback for those of us who are in the cities about how the public distribution of aid was sort of failing, why the system wasn't working. And as a result of that, we were able to negotiate with our state to change their policies about the way that they were distributing aid. And so instead of having application processes, they would just send checks to people who qualified. And so that resulted in like a $13.7 million distribution of aid that wouldn't otherwise have happened. And so I guess what I would say, like in the innovation, because the network that we're building has lifetime feedback between legal practitioners and folks who are on the ground in very remote places, that feedback circle really is, I think, breeds innovation. It tells us like in a very fast sense, like what is happening in communities and how to adjust to it. So we also realized unemployment compensation wasn't getting distributed in a fair way. So we came up with modules too about unemployment compensation. And so we could adjust ourselves in that way. So I guess what I would say, like that, like innovation is built into it because it's that rapid time feedback with our community partners that has been important. Does that answer the question?
I think so. So we'll find out, and we'll find out in the chat. We'll also share from NCMLP and our Futures friends some resources as well to help continue to bring out some more of those innovations or best practices that work well in specific communities. Nikole and all of participants, Nikole, we want to really thank you for sharing once again your expertise and your knowledge with new budding MLP practitioners, as well as those who just want to hear perhaps how they can continue to strategize to continue to reach the needs of individuals experiencing intimate partner violence, DV, and exploitation, so we can prevent and address those problems from going unmet in our communities and becoming health harming legal needs. For all of the participants, we did also plug into the chat what HRSA absolutely appreciates is feedback. And so we have to run an evaluation. Please let us know how well we did today. Let us know if you have any additional questions. I think there's an open question box in the evaluation. If not, though, definitely let us know how today's session went and what more we can provide to help and further enhance this learning experience together. Let Nikole know if you have additional questions for her, reach out to us. We'll have a follow-up email. There are resources built into the slide deck and we'll make sure you have access to it. Other than that, we'll see you on session 4, where we're joined by Jessica of the Lava Project in Indiana. Nikole, thank you again. All participants, thank you for sparing time out of your day to join us.
Thank you, Nikole. Thank you all.